Hey everyone, welcome to today's Explainer. Today, we're taking a highly structured, medically accurate journey to really demystify bulimia nervosa. We're going to break down exactly what this eating disorder is, moving straight from its strict clinical definitions to the physical signs and ultimately to actionable pathways for hope and recovery. So if you're looking for a clear, evidence-based breakdown of the criteria, symptoms, and treatment options for this condition, you're in the exact right place.
Okay, let's dive into this. Our roadmap for today is straightforward. First, defining bulimia nervosa. Second, the diagnostic criteria. Third, physical and behavioral signs. And finally, evidence-based treatment options.
All right, starting right off with Section 1, defining bulimia nervosa. So to clear up some common misconceptions right out of the gate, we've really got to start at the core clinical foundation. Bulimia nervosa is defined by a relentless cycle. It's recurrent episodes of binge eating, which are immediately followed by recurrent, inappropriate compensatory behaviors, things done specifically to prevent weight gain. And driving this entire cycle is a heavy psychological weight, where an individual's self-evaluation becomes almost entirely dictated by their body shape and weight.
Now, what's really interesting here is how we draw a clear line between bulimia and other eating disorders. With bulimia, a person's weight is actually typically normal or even above normal, yet those compensatory behaviors like purging or fasting are always present. Contrast that with anorexia nervosa, which is fundamentally characterized by below normal body weight. Or, on the flip side, binge eating disorder, which absolutely involves the binging but entirely lacks those compensatory behaviors. Making this distinction is absolutely crucial for an accurate medical diagnosis.
Moving right along to Section 2, the diagnostic criteria.
So how do medical professionals actually diagnose this? Well, they use a specific checklist from the DSM-5-TR. It brilliantly illustrates what to look for. Criterion A is the binge eating itself, consuming a definitely large amount of food in under 2 hours, with a profound lack of control. Criterion B looks for those compensatory behaviors to prevent weight gain, whether that's self-induced vomiting, misusing laxatives, fasting, or excessive exercise. For Criterion C, to formally meet the diagnosis, this cycle has to happen at least once a week for 3 months. Then Criterion D confirms that the patient's self-worth is intensely tied to their weight. And finally, Criterion E ensures the cycle isn't happening exclusively during an episode of anorexia. We shouldn't treat these just as medical jargon. They are the literal markers that help us identify someone who really needs help. Once that diagnosis is made, clinicians gauge the severity of the condition strictly by the frequency of those compensatory behaviors. It scales incredibly logically. Mild is 1 to 3 episodes a week. Moderate is 4 to 7. Severe jumps up to 8 to 13. And extreme is 14 or more episodes in a single week. Grouping it this way helps doctors tailor the intensity of the treatment to the patient's actual reality. Let's see how this builds as we shift to Section 3, physical and behavioral signs. The physical toll of bulimia is covert, but it is severe, and it affects the entire systemic body, mostly stemming directly from those purging behaviors. Orally, gastric acid causes major dental enamel erosion and hypertrophy or swelling of the parotid glands right near the jaw. The heart takes a massive hit too, experiencing dizziness, palpitations, or even dangerous arrhythmias. And that cardiac strain? That's driven by massive electrolyte chaos, like hypokalemia, which is a dangerously low potassium level. Interestingly, if a patient abruptly stops purging, they might even develop peripheral edema, basically physical swelling, due to sudden hormonal shifts. And in rare severe cases, the sheer force of vomiting can cause Mallory-Weiss tears, which are literal tears in the esophagus. It's a tremendous amount of physical stress. Now, one of the most distinctive physical markers doctors look for is known as Russell's sign. This is a dermatological finding, basically calluses or abrasions right over the knuckles. And this happens over time from the friction of teeth scraping against the hand during repeated self-induced vomiting. It's a very real, very physical testament to the reality of those compensatory behaviors. But here is the really crucial point. The behavioral signs are almost universally concealed out of deep, deep shame. Binge eating usually happens in profound secrecy and is often triggered by a negative affect. We're talking sadness, acute stress, or anxiety. On top of that, this condition rarely travels alone. It frequently co-occurs with mood disorders, anxiety, substance use, or even non-suicidal self-injury. This secrecy and shame aren't just secondary symptoms, they are massive barriers to diagnosis. And that's exactly why awareness and empathy are so critical for loved ones who might be suffering in total silence. Which brings us to a much more optimistic space. Section 4, evidence-based treatment options. As tough as the physical and mental tolls of this disorder are, the the medical community has developed some highly robust, effective pathways to recovery. The absolute first-line treatment for adults is eating disorder-focused cognitive behavioral therapy, or CBT. This specific therapy directly targets that over-concern with shape and weight, while working to practically normalize eating patterns. Guided self-help CBT is also highly recommended by organizations like NICE. Now, if CBT doesn't quite do the trick, clinicians will look to second-line therapies like interpersonal psychotherapy or dialectical behavior therapy. And for adolescents specifically, family-based therapy takes the lead alongside CBD. And here is a number that should absolutely give us all hope: roughly 50%. That is the end-of-treatment remission rate for individuals undergoing CBT, which usually involves about 20 sessions over a 6-month period. Medical intervention actually works, and this data proves that targeted therapy offers highly tangible, life-changing hope. Now, alongside therapy, pharmacotherapy plays a massive role. The first-line medication approach uses SSRIs combined with CBT. It's really important to note that fluoxetine at 60 milligrams a day is the only FDA-approved medication for this, and it generally becomes effective within about 3 weeks. What's incredible here is that it significantly reduces binge and purge frequencies even if the patient doesn't have comorbid depression and even if they haven't responded well to therapy alone. For those who do respond well, the American Psychiatric Association recommends keeping up that SSRI therapy for at least 9 months.
To put that into perspective, just take a look at the data from randomized controlled trials. For patients aiming to cut their binge episodes by half or more, those taking fluoxetine hit that mark 63% of the time. That drastically outperforms a placebo, which sat at 43%. It also radically outperformed placebos in reducing vomiting. So when we look at these stats, we aren't just looking at clinical numbers, we are looking at a dramatic reduction in real human suffering.
But of course, there are some really critical medical caveats that doctors have to navigate here. If a patient just cannot tolerate fluoxetine, other SSRIs can sometimes be substituted. But crucially, a medication called bupropion must be strictly avoided. Why? Because it carries a very significant seizure risk, specifically in patients who purge. On top of that, the use of citalopram is broadly discouraged in this context, so precision in this treatment is absolutely vital.
We've covered a lot today. We've journeyed from the strict clinical definitions of bulimia nervosa, through the severe but often entirely hidden physical tolls, all the way to the evidence-based therapies and medications that offer genuine remission. So I want to leave you with this thought. How does understanding these clinical realities and hidden signs change the way we can offer support and hope to those struggling in silence? Knowledge really is the first step toward compassion and recovery. Thanks so much for joining me for this explainer, and keep learning out there.